who has been substantially involved in healthcare regulation at the state and national level for 12 years. In addition, she's a canon lawyer and serves as a resource for the U.S. Conference of Catholic Bishops on the implementation of ethical and religious directives for Catholic healthcare services, as well as church-state relations. As a retired colonel in the United States Army Reserve for over 20 years, Dr. Hilliard was the acting deputy brigade commander of the 5th Brigade, 98th Training Division, responsible for all Army Reserve medical training for the Northeastern United States. She's been recognized by the Army for her contributions with the Meritorious Service Medal. Dr. Hilliard has served as advisor to U.S. Conference of Bishops on the Task Force on Catholic Bishops and Catholic Politicians. Quite a background, and we're happy to welcome Dr. Hilliard.
Archbishop O'Brien left out the most important part. I was under his pastoral care. He was my archbishop in the military for the military services, and you have a wonderful archbishop. We miss you very much, but we are very happy that you're here, and Archbishop Broglio has done very well in filling your shoes. So I think I'm called here the cleanup hitter. Would that be correct? I have 5 brothers, and I'm used to that term, but I want you to know when it ever came time to be the cleanup hitter, when the bases were loaded with wonderful speakers that we've just had here, they would never let me be the hitter because they would be so afraid that I wouldn't bring home the team. But we are very, very fortunate to have the speakers here. The bases are loaded with great speakers, and hopefully I can bring us all home. I'm actually going to end somewhat where we began. Mr. Smith gave a very good presentation in terms of the utilitarianism of our society. And I'm going to be speaking of that in terms of public policy, but building also on the realities of practice that Dr. Gloth has presented. I am a registered nurse, many years of practice. Certainly know the understanding of triage and end-of-life care. Many people say, well, we can't waste resources on persons because basically they have decided they're not worth it, that they don't have dignity. And no one ever loses dignity. We can stop attributing dignity to persons, but no one ever loses dignity. And when persons feel as if they are a burden, they're feeling as if they are a burden because they feel that people will not respect that dignity. And that's really what it's all about. And the realities of practice that Dr. Gloth laid out, I think, lay a great foundation for how I'm going to try to integrate all of this in terms of public policy and mandates, also laid out very well by Mr. Smith. And all important is what Father has just presented for us, and that's our Catholic teaching. But it isn't just our Catholic teaching, it's natural moral law. And our speakers all have heralded back to Hippocrates. I was a lobbyist for 10 years for the bishops of Connecticut. I was director of the State Catholic Conference. I never had to use a papal document in giving my testimony before the state legislature. As my mother would say, she lived to be 98, and she had her faculties till 5 days before she died. But she would say, sanctity is sanity. Sanctity is sanity. Reason is on our side. And Father has laid out very beautifully for us the Catholic teaching in terms of healthcare, and it is based on reason, natural law. So we don't have to use language that people would say is beyond their faith system, because it all is steeped in reality. So with that, I'm going to herald back to this utilitarianism, how society views healthcare, the greatest good for the greatest number, which is the definition of utilitarianism, how it's impacting public policy, and what we can do about it. And I'm going to be ending with healthcare reform, a hot topic, and you're so near Washington, but impacting us all, and certainly conscience and religious liberty. So the understanding of suffering as it impacts public policy, especially persons with disabilities and the elderly. I chair an ethics committee for a national advocacy group for persons with disabilities. And persons with disabilities are incredibly frightened. When I was fighting assisted suicide law in Connecticut, which is now before the courts in Connecticut, the bench actually legislating. We've seen over and over again in terms of mandates, and I'll reference that in a few seconds. But groups like Not Dead Yet, advocacy groups for persons with disabilities, were great assets because they were very, very concerned about what's going to happen to them, who's going to make a decision about their life, and who has determined for them that their life isn't worth living because of what others view as the imperfect life. So if we look at society's understanding of suffering, and Mr. Smith has really laid this out very well, but as he said, we live in a culture here where we want to do everything we can to have the perfect life and to avoid suffering. We will never avoid suffering. This is the veil of tears. We understand that. We're grounded in that in our theology. This is the fallen world, and we as healthcare providers are going to try to make it better, to try to enhance human life, to decrease suffering, but we're never going to obliterate it. But we live in a society that wants the perfect life, the perfect job, the perfect car, the perfect child, and the perfect death. And it will never be. So there's a difference between pain and suffering. And unfortunately, no one in public policy speaks to the salvific meaning as Father has outlined for us. And thank God when he mentioned, offer it up, you laughed, you understood. We are going to come to a day, I fear, when we make that statement, offer it up. People look at us, what do you mean? And for whom did we usually offer it up? That's right, say it louder. Poor souls in purgatory, which probably most of us are going to be someday unless we go right up. I know I'm going to spend a little time there myself, offering it up. We don't have that understanding. You did, and it was interesting when Father used that phrase, that it was understood. We have some great documents, thank God, for our church. And the Declaration on Euthanasia back in 1980 from the Congregation for the Doctrine of the Faith talks about the place of suffering in our lives, but also about the fact that suicide is a refusal to love. And Dr. Glath talked about persons who are refusing to let people care for them, refusing to let themselves be loved. Those who choose assisted suicide, what that does to a family, actually. Did any of you see just recently on PBS the man, Greg Hilliard, who chose assisted suicide on television, went to Switzerland? Frontline actually aired it this week. It aired the whole thing. If you go on the web, you can actually watch him die. He had Lou Gehrig's disease. He felt he had to go to Switzerland to die. Well, what does that mean in terms of his wife who was right there kissing him goodbye? What does that mean in terms of our understanding of how we are to care for each other? And we have some great documents in the church. Again, we don't have to cite them because it is consistent with natural law. On the Christian meaning of human suffering, love is also the richest source of the meaning of suffering, but it is a mystery. And John Paul II speaks to that. It is a mystery. And thank God we have our faith because we can look to Christ in terms of how he suffered for us. And often I think all of us, we're healthcare providers, and I think all of us, at least a number of us in this room, look old enough to have experienced a loved one dying. And I think of how I did care too. Thankfully my family, my brothers were wonderful too. We all had our different assignments because she broke a hip and it hadn't healed, so she was wheelchair bound for the last 4 years. And she had macular degeneration, but we happen to be Irish, and the obituaries are really important to the Irish. We call it the Irish sports page. And my mother used to call us. She read them every day, and she'd call us and say, "You went with Susie's to grammar school. Her mother just died, and you better go and to the wake." And one of my brothers, the night before she died, and by that time, last 5 days, she was barely conscious, but he read the obits to her, and a nurse came to me and criticized that. And I said, "That's like mother's milk. Caring for her, us being allowed to care for her unto death, how important that was for us, not just for her." Benedict, in hope we are saved, his encyclical, talks about suffering and being companions. Actually, there's a hyphen in the word compassion. Compassion with suffering. In this action, and I thought at first it was a typo. I thought, oh, the sentence must have, the word must have been split at the end of a line. And no, he hyphenated the word, talking about the derivation of words, compassion with suffering, and companions on the journey with bread. We're supposed to be Eucharist to each other. And the true meaning of humanity is essentially determined in relationship to how we care for others, to suffering and to the sufferer. This holds true both for the individual and for society, a society unable to accept its suffering members and incapable of helping to share their suffering and to bear it inwardly through compassion is a cruel and inhumane society. And that man with his wife there by his side committing assisted suicide with the Lou Gehrig's disease, yes, it's a very, very terrible disease. But there's other ways to treat his suffering, to treat his pain, even to treat his shortness of breath, and to abandon persons. And we're doing it at the beginning of life. We have IVF, where people select children by qualities, and then do reduction of the children, if too many have been planted in the uterus, selective reduction after they've done some genetic testing. Can you imagine being the sibling that survived that? Can you imagine being the child, wondering if I'm not the perfect cheerleader or football player, would they still care for me after they knew their parents had made such selections? And that's where this is all headed, selections in terms of wanting the perfect life and the perfect child. Right here at Johns Hopkins, they've done a study of clinics that do pre-implantation genetic diagnosis. 42% of them already are offering sex selection. Now, why the feminists aren't enraged with that is beyond me. I don't understand that. And actually, Johns Hopkins' own study of how many, what the percentage is in terms of actual cases, it's 9% of the pre-implantation genetic diagnosis in this country is for sex selection. Quite frightening. We all should feel vulnerable if we're attributed dignity based on a personal quality, as Dr. Gloth had outlined. And Mr. Smith talked about the Groninger Protocol. He spoke of it as actually not being legal, but it is because it's publicized. People know they're doing it. It's actually the way in Holland that assisted suicide creeped in. There were policies in place that wasn't legalized and then became legal. But if you look at these criteria that parents and physicians look to decide which of their neonates are going to live or die, number 2, particularly, hopeless and unbearable suffering, but it can only be anticipated that this child would have hopeless and unbearable suffering. For example, spina bifida. I'm a graduate of Children's Hospital in Boston. That's where my RN is from, and I worked there for a while in their neuro ICU. So a lot of beautiful children with spina bifida who had great therapies and have very productive lives. We followed them through their childhood. But it only has to be anticipated suffering. And then both parents must have informed consent, and the infant is killed in accordance with accepted medical standard. And this hails back to a good standard to kill a patient that we heard about earlier. How outrageous. It doesn't even make sense in terms of what we're called to do no harm as healthcare providers. If you go into your yellow pages, you are going to be able to find the Hemlock Society. It's by euphemism changed its name to Compassion and Choices. And actually, if you keep searching on the web pages, there's information on how you yourself can commit suicide, showing you how to do it. So it's bigger than anyone really wants to admit. It's infiltrated a lot of good efforts to provide compassionate care at the end of life. You'll find them at the table. We had in Connecticut, I was a co-founder of the Connecticut Coalition to Improve End-of-Life Care. And actually, a sister who's sitting in this room, Sister Claire Hunter from the Franciscan Sisters of the Eucharist, her father is now the president of that initiative. And we used Robert Wood Johnson money for it. We took $250,000 And we used it. The State Health Department was involved, Yale Medical School, UConn Medical School, and we gave conferences like this throughout the state on good pain control. What are good alternatives to assisted suicide? And yes, there were people involved in that group that would not be where I am in terms of sustaining and protecting human life. But we were trying to educate those who would have other views for good alternatives. But there are persons in initiatives such as that who would have views similar to the Compassionate Choices initiative. And we have to be at the table, and we have to have alternatives. They're out there. We do know we live in a society in which consent is sacrosanct. And this can lead to persons saying, as we heard earlier, that those of us who have the views that we have no right working in emergency rooms if we won't administer an abortifacient. I know when I signed in and raised my hand to be an Army nurse, my master's degree in nursing is in maternal child health. And the Army, thankfully, military will not do abortions, your taxpayer dollars, except when we look to healthcare reform that I'm going to end with, it's in there. But right now, your taxpayer dollars are not used for abortion, so they're not done in the military. But contraceptives and IUDs are inserted. And I said, when I give my oath of office, it says without reservation, you need to know ahead of time I will not do contraceptives. And that was accepted. I was allowed to do that. But I'm not sure that's going to be true because in the future, because people are saying consent is sacrosanct. In other words, those of us who are healthcare providers are like persons who service a car. Come in, tell me what you want to do, and I'll do it. The ethical and religious directives are very clear. We do respect consent as long as it's not contrary to Catholic moral teaching. You have a great healthcare directive for the diocese and the Catholic Conference of the state. It is in the back of the room, and it also addresses that. And we have at the National Catholic Bioethics Center a model policy for Catholic healthcare agencies in end-of-life care, and talks about the conflicts and how you would address them between the provider and an immoral advance directive. So I would just refer you to that. By the way, the National Catholic Bioethics Center has a 24/7 consult line that's free. I coordinate it, and we have, within 1 year, 1,474, but who's counting, consults that come in, and it's open 24/7, and it's a free consultation service. So we invite you to use that. But we have some great resources that would help with that and help you with that, because clearly we will follow an advance directive, but it must be consistent with Catholic moral teaching. Now, we've already addressed the issue of advance directives and healthcare agents, but one of the things that is in the ethical and religious directives, there are statements that pertain to these advance directives. And as I think we just heard, less is better, perfect, less is better. We really advise people that the best thing to do is have a healthcare agent who knows the mind of the church and your wishes that you have spoken to, because you cannot anticipate 5 years, 5 months, 5 weeks, 5 days, the scenarios, all the particulars that will be presented to you. So a good conversation with a healthcare agent is the better way to go. Dr. Haas, our president, received from a priest 35 pages of an advance directive and asked him to review it, and he wanted to know if it was long enough. And Dr. Haas said, no, it's not long enough because you couldn't possibly anticipate all the scenarios. If you wanted to, it would be volumes. So a good healthcare agent, but with some advisement. And that advance directive, especially the one that your Maryland Catholic Conference has put out, would be providing sufficient directive to family making those decisions. Many times when we get these calls, and we get them a lot, it will start with a lot of them are nutrition and hydration right now. But it will start with someone who says, I'm not the healthcare agent for my mother, but my brother is, and he's no longer a practicing Catholic. I'm really worried about, because Mom said once she didn't want to be on machines, and what is this, how is this going to violate the Catholic Church if we don't provide her? She's no longer eating. We no longer provide her with assisted nutrition and hydration, but she would also want to be faithful to Catholic teaching. And at least we had some idea that she wanted to be faithful, but sometimes we have no idea because Mom didn't want to talk about it. So good conversations. And I'll just add a little bit more to what Father said as I get a little bit further in terms of the ethical and religious directives of how that can get sorted out. But back to the public policy piece, we have seen that, again, persons are making decisions about the quality of life, a terrible term of persons. It means that we have said that because they are suffering, they have no quality, therefore they have no dignity, basically. And some of these cases have actually gone to the Supreme Court. And these are two cases that were in the state of Washington, and at that time, unfortunately it's changed, and New York, in which the state laws prohibited assisted suicide. And it went to the Supreme Court because physicians, and this is happening in Connecticut right now, they're going to the courts, where unfortunately many times courts are actually creating law, not just interpreting the law. And these two cases went to the Supreme Court, and the physicians were saying, this is impinging on my practice, these patients needed to be assisted to die, and the state's not allowing me to do that. Again, the law has changed in Washington, unfortunately. But Chief Justice Rehnquist had some great statements, and he looked to Holland, where assisted suicide was already occurring in great frequency, and he stated that there is no constitutional right to assisted suicide in our Constitution, that it would undermine the role of the physician as healer, expose the vulnerable to abuse, and initiate a steady decline toward euthanasia, and actually undermining the state's interest in protecting the vulnerable. And if we can see where this has gone in Holland with the Groninger Protocol, we can see it really has had, that slippery slope was not just a phantom. It is true that it undermines society and the profession. And we've moved to state-sanctioned killings. In Oregon, there was a 10-year study, and it was alluded to earlier. It's been published by the American Medical Association in terms of the reasons persons request assisted suicide. One of the highest reasons is loss of dignity. Well, what does that really mean? It means I will be what? Abandoned, considered a burden. And the lowest two reasons, as cited earlier, the lowest two, pain and finances, which are always touted in state legislatures as the reason for needing it. People do not want to be a burden because they've been made to feel that they have to be the perfect person for society to value them. We now have a third state. Oh, by the way, in Oregon, the law, and in Washington, the law says that if there's ever any evidence that the persons are making this decision in relationship to some psychological trauma or not good mental health, they should be referred for counseling. And in 2007, there were 49 persons assisted to die. Not one of them was referred for counseling. Not one. We know depression is a big part. Depression and pain, a big part. We can control them. We can deal with them. Again, activist judges are creating mandates and creating changes in policy. We see it in terms of mandates, in terms of our Catholic health care. And in Montana, it was a judge who ruled that assisted suicide was legal just last year. And it's been to the Supreme Court of the state of Montana, so it is now the law in Montana. The legislature right now is trying to look at that because, again, activist judges creating laws. Legislatures are now, some of them, stepping up to the plate to try to reverse that. And Mr. Smith talked about the issue of terminal sedation, which is different than palliative sedation, where a person's pain cannot be controlled very rarely, and we have to give them enough medication that they are rendered unconscious, but then we provide them assisted nutrition and hydration, so we're not starving them to death. This has passed in California. It's a watered-down version, but it's a rose by another name because it still will protect a physician who is given, and he must give, all the alternatives to a patient. A patient might say, I've been terminally diagnosed. That means I'm going to die supposedly in less than a year, and I just can't understand this disease. I can't cope with it. I am so emotionally distraught. I want to be rendered unconscious, and I don't want assisted nutrition hydration. The physician will be legally protected from engaging in that practice. By the way, your great Maryland State Catholic Conference had it before your legislature last year and defeated it. It passed in Vermont, however. So when we talk about how you can handle all of this, I'm going to talk about your Maryland Catholic Conference and how important it is to work with them to make sure that our legislature doesn't pass laws that are really against natural law. And we know from the ethical and religious directives that euthanasia can be more than active, it can be passive. And by denying someone nutrition and hydration, it is passive euthanasia. We do know also that palliative care is a great alternative, and methods to control pain, even under the principle of double effect, are morally licit. And this hails back, the whole issue of extraordinary versus ordinary means goes back to Pius XII, who laid them out very clearly, and John Paul in the Gospel of Life talks about this position in terms of the ability under the principle of double effect to give narcotics. And here is the principle. The act itself must be good or morally neutral, and that is controlling pain through the administration of medication. There are two understood secondary effects or effects, but the intent is the good effect. The good effect to relieve pain is intended. There can be other effects, one of which might be the respiratory depression, but we're not choosing that. We just can anticipate it, and the circumstances are consistent with it, that there is no other alternative. Again, in our 24-hour consult line, we get calls like this a lot, and I was actually coming out of church and my phone was vibrating, and I'm in the car, and a wonderful young man called. He was the healthcare agent for his aunt. And he said, this doesn't sound right. I've been watching my aunt. She has COPD, chronic obstructive pulmonary disease, end stage, and they're giving her morphine to decrease her respirations, to depress her respirations. That can't be right. And I said, well wait a minute. Let's tell me what happened when they gave her the morphine and what happened before, what she looked like before. Well, she was gasping and she was air hungry and she was frightened. And well, what happened with the morphine? Well, she just calmed down and she was peaceful. I said, oh, no. This is morally licit. It's okay. Yes, it might hasten death by suppressing further her respirations, but her air hunger is being treated. Classic example of what's morally okay. And again, the ethical and religious directives speak to what is a proportionate versus a disproportionate burden benefit, and the right to actually make a decision, but it's the patient or the surrogate who should be making that decision in terms of what would be proportionate. In our guidance that we have here, our model policy for Catholic healthcare agencies, we have a definition of procedures that only prolong the dying process, and they would not be something that's mandated. Any therapy or intervention which uses mechanical or other artificial means to sustain, restore, or supplant a vital function necessary for life when, by reasonable standards of medical judgment, it is anticipated that death is imminent, or where the benefit of the procedure to the patient is outweighed by the burden to the patient, when the procedure's risks or side effects are contraindicated for the well-being of the patient. This is of the treatment, not of living. And people say, well, life isn't worth living and it's a burden. No, we're talking about the treatment. And is the treatment itself going to be a disproportionate burden? And our ethical and religious directives speak to that. And Father has outlined these, 56 and 57, speak to the times in which they're required or they may be withdrawn or withheld. We also heard of John Paul's allocution on nutrition and hydration, even assisted nutrition and hydration, being ordinary care. And there was a dubium, a doubt, and the bishops of this country went to the Congregation for the Doctrine of the Faith and asked, how does this apply in terms of persons in a persistent vegetative state? And the answer again was that in principle, this is ordinary care. Therefore, the bishops of this country met and last November revised the Ethical Religious Directive number 58 and spoke to the fact that in principle this is ordinary care. But again, as Dr. Gloth and Father have just laid out, it's not always required. And I'll just read the end of that directive that shows you we must weigh the scenario for each patient. Again, why the healthcare agent is so important. Medically assisted nutrition and hydration become morally optional when they cannot reasonably be expected to prolong life, or when they would be excessively burdensome for the patient or would cause significant physical discomfort, for example, resulting from complications in the use of the means employed. We had a woman who called us, and I found out through talking to her, I don't think she was even a Catholic, but she happened to see us on EWT, and I think it was Father Tad, your classmate, Father Tad. And her husband was riddled with cancer and on dialysis, and she asked me if dialysis was now morally required. And when she gave me the background, it was no longer morally required for him. And the reason I think she was not a Catholic, I used the layman's terms, has he been anointed, which of course is important. And then she said, well, he's been baptized. So then I realized that we were, in terms of our faith, speaking a different language. But in any event, and she then said to me, well, but he has IVs and tube feeding. We'll have to continue that. And I said, oh, no, because once the kidney shut down, the assisted nutrition hydration would be contraindicated. And then she said, well, then I can't stop the dialysis. She didn't understand because she thought she always had to provide assisted nutrition hydration, not the teaching of the church. We use prudence. If there's a conflict, go to your ethics committees. One of our graduates, we have a certification program, and one of our graduates of our certification program, it's all online by the way. At the end of it, you can transfer to another school and get online a master's in theology. So go online and look at our program, and one of our graduates is among you and on your ethics committee. But very important resource, very, very important resource for Catholic health care. What we're seeing, where this is all ending up, is because we haven't made good decisions in our delivery of health care, and a lot of people, as Dr. Gloth has spoken to, end up dying in intensive care units in their last days and last months of life, when perhaps it was an extraordinary mean. We haven't done good education of our physicians, and that was spoken to also. And so the states, legislatures, public policy at the national level all seems to be taking over, creating mandates. And I think if we look at our healthcare reform proposals, we have to look really very, very carefully. And what I have here are some concerns to be looked at, and we also have on our web pages an analysis right up to date in terms of the current one with President Obama's proposal that he is suggesting and the reconciliation process. But these are the things we need to look at. Be assured that the current proposals do include the public supportive programs that include abortion. They definitely do, even if separate checks are written. You will see that there's been some concern about public options. Our concern is as soon as there's a public option, private employers are not going to provide insurance. We'll have a universal single-payer system. The largest provider of health care in this country is the Catholic Church, and the mandates that will be increasing, saying that we are agents of the state. We have to have great, great scrutiny of these proposals. The conscience protections in the Obama plan, no one will have to agree to do an abortion, but no mention at all about the abortifacients, no mention about things like the morning after pill, nothing there that will protect us once we become these agents of the state, if we do. We agree, absolutely, we need healthcare reform because the largest provider of uncompensated care in this country is the Catholic Church, probably right here. We need that, but we need conscience protections. And we should not be discriminating on the basis of age, disability, or prior conditions. And yes, there is a 15-member advisory panel right in the proposal that is not to propose rationing. However, there'll be monetary incentives for those who can cut costs in the delivery of care to their Medicare patients. It's in the proposal that they will share in the by cutting costs, including preventing readmission. So we would ask you to go to our webpage, but keep a close eye, because the way we make change is working through agencies like your state Catholic Conference, working with them to impact. They're at the legislature every day. You have a great state Catholic Conference. You really do. And working with them. So these mandates, right now, you're right next to D.C. The D.C. Catholic Charities had to give up foster home placements as well as publicly funded adoption. All the dioceses in Massachusetts had to give up adoption placements because of same-sex marriage laws. So work with your Catholic Conference so that you can have the ability to give care consistent with natural law. Because utilitarian is what dictates law at our legislatures. Thank you very much for your attention. I think we'll make a good call.